Welcome to our April method seminar. We used to call it CHIPTS method seminar and CHIPTS Center for Community Health, but now it's just called CHIPTS method seminar. So today we're very fortunate to have one of our own highly competent postdoctoral fellows, Dr. Priya Bhagwat. So I think many of you are in HIV field, and I think in the past 30 years or so we made so many advances in different types of drug regimens to combat HIV, and I think one of the later class of drugs is the integrase inhibitor drugs, and which is really exciting. And I think there's been cases where patients who had viral rebound on many different regimens, when they got back on integrase inhibitor, they called it like a salvage therapy, where they were able to reduce their viral load. So I think there are many exciting stuff going on with integrase inhibitors, but at the same time, as you will hear from Priya's talk today, there's some cautionary side effects. So in this particular case, we're looking at measurement of abdominal fat changes and predictors of excess fat gain in HIV-infected individuals initiating therapy. So welcome everyone, and enjoy the talk.
Hey everyone. So I just give some background. I graduated from UCLA, started postdoc last year, and I was in the epidemiology department. So this is the research I was doing when I was part of the epidemiology department, under the guidance of Judy Courier and Kamina Gorbach, were my co-chairs for my research. So just to give some background, having HIV has become a long-term disease. The proportion of individuals aged 50 years or older who are living with HIV is on the rise globally, as you can see in the graph here. ARVs have decreased mortality and increased the longevity of individuals, leading to the development of aging-related conditions. So one of these conditions is cardiovascular disease, and it's a comorbidity of HIV, and HIV-infected individuals appear to be at a higher risk for CVD, and both HIV infection and antiretroviral therapy may impact CVD risk, and continued inflammation from HIV infection is associated with an overall higher long-term risk of CVD, despite the benefits of ARV therapy. So ARV therapy has been associated with metabolic complications, including fat abnormalities. And these fat abnormalities include fat loss and fat gain in certain areas of the body. I'm focusing on central fat gain. So central fat gain often includes increases in abdominal visceral adipose tissue, and you see these after individuals initiate therapy. So I'll call visceral adipose tissue VAT for the presentation. So VAT is an important risk factor for CVD. We have a diagram here just showing the different fat tissues in the abdominal region. So you have the two major types, which are VAT and subcutaneous adipose tissue. So why is that important? So VAT has been found to be more metabolically active than subcutaneous adipose tissue, and it's involved in lipolytic activities and more release of pro-inflammatory cytokines. So this is kind of a hypothesis of it's called the portal theory. So it's hypothesized that VAT releases free fatty acids through the portal vein into the liver, and ultimately part of the fatty acids pass into systemic circulation. And in previous research, it's been found that visceral adipose tissue in HIV-infected individuals is associated with a higher odds of 5-year all-cause mortality, as well as other markers of CVD risk. And certain antiretroviral drugs are associated with VAT accumulation more than others. So the overall objective of my research, so it's important to understand the different effects of various ARV combination therapies and other predictors on body fat composition changes, including VAT changes. And so my overall objective is to identify simple approaches to measure and predict excess fat gain in HIV-infected individuals starting therapy. So hopefully we'll be able to get through all of this research. I'm going to try and get as much of it out as possible. So my first study was I examined accessible measures of abdominal fat gain. The second one, I investigated predictors of abdominal fat gain. And the third one, I investigated predictors of severe weight gain after therapy initiation. So just to give you a background of the study populations that I used for my research. So I primarily used ACTG A5257, and this was a phase 3 randomized trial that ran from 2009 to 2013. Subjects were treatment naive, men and women age 18 or older, and they were randomized in 1-to-1-to-1 ratio to 3 regimens, including raltegravir, which is integrase inhibitor, darunavir, which is a protease inhibitor, or atazanavir, which is also a protease inhibitor. And each of these 3 drugs were given in combination with a TDF-FDC backbone. And the duration of the study was 96 weeks.
What does 1-to-1-to-1 ratio mean?
Meaning that if they were, third were given this drug, a third were given this drug, third. Yeah?
Sorry, what exactly is a phase 3 clinical trial?
It's just, it's like after you've seen that there are 4 different levels of clinical trials. So phase 3 is after you've seen that the safety is okay, then you move on to a larger study population and you try out the drugs for efficacy and tolerability. Okay, so there was a sub-study of the ACTGA 5257 study, which was the metabolic sub-study, which was called, I'll call it for this reason, A5260S. So this sub-study involved, so there were 1,800 subjects in the big study, and this was about 300 subjects enrolled in the sub-study. And the whole point of this sub-study was to evaluate the effects of HIV disease and ARV therapy on cardiovascular and metabolic outcomes. And so the primary analysis of the study compared changes in body fat associated with these 3 treatments, and they found that while all 3 treatments were associated with abdominal fat gain, there were no difference between the study arms. And this could be due that they couldn't find a difference because of the small sample size of the sub-study. But for the whole big 1,800 individuals that were enrolled in the larger study, there were measurements of other measurements that were collected, which were waist circumference and self-reported abdominal fat gain. So, so by testing the reliability of these other forms of measurements, we could use them to look at the association between the treatment regimens and fat gain in the whole cohort instead of just the sub-study group.
Yep. Were the 334 randomly selected, or was there some criteria?
I think it was just specific sites that agreed to be part of the sub-study because they had to have extra measurements like DEXA and CT, which I'll talk about, and so you had to volunteer to be part of it.
Sure. So everyone's getting ARV therapy.
Yes. And everybody didn't have it before they started the study.
Right. So you're looking at the effect of different types of ARV therapy rather than not having it, because everyone has to be treated.
Yes, everybody's getting treatment. Yeah. So the effects of getting therapy, initiating therapy, and the different types of therapy that you're initiating. So I'll move on to the first study. So this study, I looked at the association of changes in abdominal fat with waist circumference and self-reported changes. So now this is just looking at the sub-study and seeing the validity of these more simple forms of measurement, such as waist circumference and self-reported fat. So it's important for clinicians to be able to assess CVD risk in their patients accurately and efficiently. And one important factor for HIV-infected individuals to assess CVD risk that can be monitored is fat accumulation, as we talked about. So a CT scan was used to measure visceral and total abdominal fat, and DEXA scan measures trunk fat mass and cannot distinguish between the different adipose in the abdominal region. So waist circumference, just to give some background about what was found with waist circumference, it's been found to be associated with visceral and total abdominal fat, but changes in waist circumference have not been extensively examined. So it's important to understand if waist circumference is associated with these standard measures from CT and DEXA. Self-reported measures have also may also be a valid surrogate for and be more less cost-effective and more labor-intensive measures that are DEXA and CT. And ARV studies have used self-report to measure fat change, but and some have tried to examine the validity, but really these studies had conflicting results, and nobody really looked at change in abdominal fat. It was always cross-sectional, like if you feel like you've gained weight, how do you feel versus how do you look right now versus monitoring over time, which is what this study was able to do. So the objectives of this study were to first look at waist circumference was correlated with the CT and DEXA measures, and also then look at self-reported changes were correlated with the CT and DEXA measurements. So measurements were taken at week 0 and week 96. For some reason, with all these clinical trials, it's 0, 48, and 96 are always the weeks. And so this duration was for 96 weeks, so we used the full duration. And as I said, the sub-study, this particular study was using the sub-study participants, which were about 300 people. And waist circumference was a continuous measurements, and self-reported self-reported belly size change from was reported at week 96 and was categorized as lost no change, gained some somewhat larger, and gained a lot much larger. And then the standard measures from DEXA was trunk fat mass, and from CT scan was visceral and total abdominal fat. So I call it VAT and CAT. Otherwise, it's enough. So we also examined the associations across multiple demographic variables, including sex, baseline BMI, race, ethnicity, and age.
Can I just ask, what was the main hypothesis of the phase 3 clinical trial?
I had that in there. Yeah, just for time I cut it out. But so the main thing was trying to understand what the efficacy and tolerability of darunavir, atazanavir, and valtegravir, the three regimens, and they found that while all three were efficacious, so they all suppressed had viral suppression that was similar. Darunavir and atazanavir, or I think it was valtegravir had better. Valtegravir and darunavir had better tolerability than atazanavir. So then the national guidelines kept atazanavir as a second-line regimen option based on the results of this study because of tolerability reasons.
Which reading side effect?
Yeah. So to look at self-reported changes, we used ANOVA to examine differences between the group means of DEXA and CT measures that change across the different self-reported categories. We also did linear regression to analyze any trends between the measured and self-reported data. And of course, we looked at subgroup differences in self-report because self-report could be different for different demographic subgroups. So for our results, we have the overall and sex-specific means of trunk fat, VAT, and CAT across self-reported abdominal size change categories. And so really the takeaway here from the ANOVA models and from, not to get into all the details of the ANOVA models, and then we did all the pairwise contrast, is that you see a trend here where self-reported category reflected the relative abdominal size change experienced by participants, meaning as people said that they gained more weight, their actual measured CT and DEXA abdominal fat measurements also increased with that.
Why is it, I wasn't quite sure what that and cat were, and now I'm really sure, given that it says 7 meters squared.
Yeah, so
it's an area?
That's how CT measures it. It's an area.
It's not either a volume or a mass or.
It's very confusing when you look it up. They call it a volume, but it's measured in centimeters squared because I think it's like an image. How they measure it.
Are they measuring it sideways or something?
I think maybe cross-sectionally. As I've seen some pictures of it. I didn't get to see the actual images from this data, but just looking into research on how these CT scans are performed. But yeah, and then
so they find one plane that's the same on everybody?
I think so.
Like 6 inches above the hips or something?
They have standard ways of doing it. Even with the waist circumference, it was like certain amount above the hip, certain amount below, and they would take 3 measurements. But yeah, I'm sure with the CT, I didn't have those details.
I can add that.
Yeah.
Between L4 and L5.
Yeah, L4 and
L4 and
L5.
Of
the spine.
Oh.
The standard between L4 and L5.
L4 and L5 have different meanings in different disciplines.
No worries. I'm sorry, I just wanted to put I know it. Sorry about that.
Can you go back?
Yeah, sure.
Interested just looking at the standard deviations being as larger than the means, which is indicative of skewed distributions. Although it also in the no change loss, I guess these measures. I'm confused because a mean those can be negative, I guess.
Yes, they could be negative.
So those are change scores?
There's change scores.
Oh.
From week 0 to week 96, it's a change.
Oh.
So we're trying to see. Sorry. It's not like a not a cross sectional. So it's like from week 0 to week 96, when they reported at week 96 how their abdominal size changed. What is the actual measurements from these CT and DEXA scans from week 0 to week 96? How did
and so we're to understand that fewer than 10% of the people thought they gained a lot of weight and so forth. But
Yeah.
when they just trying to get a sense of whether get a sense of the extent to which the self-report align with the more, if you will, objective measures. Did you look at that? The extent to which the no change lost gained somewhat larger, gained a lot much larger. Do those self-report ratings correlate well with the?
That's what we found. Yeah. Yeah, and I have a lot of other data and tables that show that where we did linear regressions, we did ANOVA, and all these things, and I couldn't put them all here, but yes, the general result from this was that we thought that it was it was a small sample size of what we saw, but we couldn't really see it in the females, and so that's what I wanted to show in the next slide, because,
Quick question. Back to the
sure.
slide. So,
Of course.
so were you able to look at this sort of stratified on baseline levels of fat?
Yeah, on BMI, baseline BMI.
Right, so
Yeah.
I'm assuming that if you're, so for example, for someone who's really starting out to be relatively overweight versus who are slim,
right.
I think the changes have different meanings.
Right. So I think we found that it was still pretty correlated with those that were overweight, but with the obese, there was like a mix of results. Like some, depending on the fat, showed correlation, but it was such a small sample size for the very obese population. So it could be due to that. It could be we're not ruling it out. Maybe it's not working as well in that population.
So
but
were there any patients who were like normal weight?
Yeah, and it was pretty correlated with them. Yeah.
Okay.
Yeah, I have other tables that show all the subgroups, but generally it was pretty robust in all the subgroups except for ones that had small sample sizes, or maybe it's just that like maybe for example females, it doesn't work as well, and self-reported fat is different, and other research has shown for weight and things like that, females reported differently, but we also had only 10% females in the sub-study, 10% of 300, so I mean that's what this next graph is showing. The females are in orange and the males are in blue, and you can kind of see a nice trend with the males, but the females it's a little difficult. It was a small group. So the second aim of the study was to look at waist circumference, and we used Pearson correlation coefficients, and we looked at the change in DEXA and CT, as I said, from week 0 to week 96, associated with the waist circumference change from week 0 to week 96. And then also, we examined self-reported abdominal size change and waist circumference together in a joint model to kind of compare the predictive ability of the two variables, like which one's better, how do they both function together in a model. So just for waist circumference results, here we have the sex-specific changes in trunk fat, fat, and fat between week 0 and week 96 across waist circumference changes. And also, I mean, these aren't the numbers, it's just a visual representation, but we have them in here. So you see it's pretty correlated. Pearson, they showed a strong correlation between changes in waist circumference and changes in trunk fat, fat, and fat. And then in most of the subgroups as well, except for, again, some small sample size subgroups. So waist circumference was good overall between everybody. And so for the joint models, so we found that the R-squared values of each of the joint models, including waist circumference and self-report together, were modest. When included together in the model, both waist circumference, so there's the R-squared, both waist circumference and self-reports continue to remain significant predictors of trunk fat, fat, and fat. And the differential mean change of trunk fat, fat, and fat for the gained much larger group compared to the reference group, which was no change loss. So this is the extreme group compared to the no change loss, which was the reference group. That was also significant, which kind of shows that self-reported abdominal size change may give additional information about those with extreme changes in abdominal fat, possibly. So, discussion. So in the study, we found that self-reported abdominal size change was strongly associated with CT and DEXA measured abdominal fat changes, and the stratified analyses showed that the usefulness of self-reported abdominal change may vary by subgroups, which we talked about, and waist circumference measurements were also correlated with all the abdominal fat changes, both overall and in most subgroups. And so because monitoring this adipose accumulation is really important, the findings of the study show that that these more affordable forms of body fat assessment may be adopted by clinicians for monitoring CVD risk and abdominal fat changes. But I used then, from this first study, I said, okay, so these measurements seem pretty good, and now we have collected both of these in the big cohort of 1,800 individuals in the study. So now I can take this information, use these measurements as an outcome, and now look at predictors of abdominal fat gain in the entire cohort with waist circumference as an outcome or self-reported abdominal fat as an outcome. So this was the next study. So the first aim of this study was to examine the association of predictors, and I'll go through them with you, with waist circumference changes in the parent 5257 cohort. And the second aim was the same, except using the outcome of the self-reported abdominal size change. So the predictors that we were interested in were treatment, which we talked about, added-vanderveer, dronabinol, or ticagrelor, demographic characteristics, race, ethnicity, sex, and age, and baseline characteristics, BMI, CD4, and HIV RNA.
So just
Yeah.
you could have done that if you're looking at the effect of treatment. Could you have also done that just in the 300 in the sub-study?
So they did that.
Uh-huh.
So they did that in the sub-study, and that was the primary results from the sub-study, is that they found that all three treatments had an increase, significant increase in abdominal fat, but they couldn't find a significant difference between the treatment groups. So we wanted to see if we expand this to the full study.
If you were picking up a signal because of the increased sample size.
Yes.
Got it.
So first we wanted to see are these valid measurements, and now can we use this in the 1,800 subjects?
So the sub-study where they saw an increase across all three drug regimens, was there a consensus in terms of their conclusion?
They just couldn't. They said we can't conclusively say which drug is better or worse.
But the conclusion is that the drugs caused them to gain weight?
Well, not cause, but starting treatment.
Okay.
So going from no treatment to starting treatment definitely was associated with weight gain. Whether it's the drugs or the drugs interacting with, different immunology aspects, I think I'll go into that in the discussion, what's causing this weight gain.
Yeah, so I think as a non-clinician, I'd be curious to know, like, in terms of their, the fact that they're doing well because they're on the drug may sometimes contribute to their weight gain. So
Right.
For example, like if you're treatment naive and you're not doing well, like in terms of your, you being immunocompromised, and then you get on this treatment, and then your appetite increases, and then you're eating more food, then maybe the side effect of being on treatment is that you're feeling better and you're eating more.
Right. So that was like the third study that I have here, is kind of dealing with that and kind of to tease out a healthy weight gain from an unhealthy weight gain. So that one we'll talk about as well. Okay. So then our outcomes, as I said, were waist circumference and self-reported abdominal size change, which we've already talked about. Okay. So we used the entire 5257 cohort, and we did repeated measures models to determine the association between the predictors and waist circumference gain. And so this is the first aim, that's just dealing with waist circumference as an outcome. And then, this is where I was talking about the primary metabolic results, what they found. And so primary metabolic results from the whole cohort saw that raltegravir was possibly associated with a higher increase in waist circumference. And we wanted to dig a little deeper and examine potential effect measure modification of treatment by sex and race, meaning do these treatment differences differ between what sex you are and what race ethnicity group you are. And then also we looked at the association of all these predictors and waist circumference changes. And we adjusted for confounding from smoking, drinking, drug use, income status, and insurance status.
Question. So this is a bit of a pet peeve of mine, but maybe I'm missing something here. Are you using repeated measures models with two time points only. The question then would be, why not just look at change score?
Change score. I think we decided to go. We did change score as well, but we did a lot of sensitivity analyses just to make sure it was consistent between. But I think we decided to go with repeated measures models just because we wanted to see where people started off with and where they were going. And with the change score, we would just see their change score. We wouldn't be able to see what the differences are on baseline as well.
Well, they're different models. I mean, some of the other ones we're more expert than I on this, but like you could have the change score be the outcome, and the baseline value could be covariate. People with higher values of baseline might have more room to improve, that kind of thing, or depending on what the directions are. Usually, I mean, I've always understood the motivation for repeated measures models as coming from situations where you had 3 or more measures. But what's your?
I think the previous study should have been done with repeated measures too. And then you've got the estimates of the follow-up, you've got the estimates of the baseline, and you can subtract. So you can subtract 8 after fitting, and it gets all the correlations correct. Missing data is pulled
Missing
in the
data, I was going
column.
to say, yeah.
You get fills in the missing data correctly. And you still get the differences. So you still get the change score. The change score is a target, but it's not. You don't mess with the data first and then analyze second. You analyze first and then.
So you like doing it because you get the correlation as an inter-class correlation of the byproduct of the estimation.
And the change score there's weird things going on there. Suppose the baseline has a 0 correlation with the change. That means one thing, and suppose there's it has a correlation of 5. That would mean that the follow-up outcome is uncorrelated with the baseline, which would be a really odd result. So you get these odd things that are difficult to interpret with the change scores and outcome, and it's much easier to interpret in terms of if you do the full repeated measures model. I find.
Do you have perspective on this issue?
I think I want to see the model before I'm ready to
That's a good answer. Good lawyerly answer.
Why don't I see the
Okay. So,
I think you're going to see.
Oh, we're not going to see the model.
No, you're
no,
not.
the model. I'm just trying to give an overview of my study. Yeah.
Trying to sneak in.
But just to go back on that, I think the main points of why we did it for the missing data, for the accounting for correlation, the different measurements between subjects, and we also did change score to show that results were consistent. We did I had to cut out a lot of stuff. We did a lot of sensitivity analysis. We did per protocol analyses. We did influence analyses. We just wanted to show that these results were.
So just maybe you could just say a few words about the repeated measures model. What the dependent variable was?
The dependent variable in this, depending on what. For this one, it was treatment, and there was a treatment by sex and treatment by race ethnicity. Of course, by time, like the 3-way interaction between time, treatment, and sex, and time, treatment, and race ethnicity for the effect measure modification.
So the outcome.
The outcome was waist circumference change, week 0 and week 96.
Right. So week 0, you wouldn't expect any treatment effect, right?
No.
Right. So that was kind of built into the model in some way. I mean, so there would be no treatment effect at time 0, right? So.
Yeah. Yes. I guess all it was saying, what only treatment effect is just to count that their baseline waist circumference, that one group didn't start off bigger, right? And that they were having bigger waist circumference changes, like if the root of your group happened to be larger or something.
No, but I guess I think what Dr. Brickner is getting after is that you might have by having an interaction between treatment and the baseline score, maybe that would pick up.
It wasn't. It was between the time, so it was between the change, the interaction.
You had treatment by time.
Yes, treatment by time.
So that might.
That's 6 parameters. So there's 3 for the baseline and 3 for follow-up. I mean, there's different means in baseline, which you can get rid of, and you save 2 degrees of freedom, which is reasonable, but you don't find out, you can't estimate the, you can't check the randomization if you make them all the same, basically. For this model, you're paying 2 degrees of freedom, you do get to check your randomization.
Randomized trial, you've got 1,000 people.
Yeah, well, I don't know.
Well, anyway, let's hear the results.
Did you come to a consensus conclusion then of what's the application of when to use repeated measures for this type of versus?
Always.
Sometimes.
Never.
I think
I vote for always.
I think that what we're this colloquy going on here is partly that, and I think that Ron's question was a great one too. That you can have repeated measures models that don't make a lot of substantive sense. If you had a model that had a main effect for treatment, but in reality you wouldn't expect a treatment effect at baseline, and you would potentially post baseline. It's funny or odd to that was what you were getting after that understood correctly that to say that there's a main effect of treatment that somehow is the same at baseline and at post baseline. And so if you're, so long as you're, I think that
You don't want to do that.
you don't want to do that. But what Rob is saying is you always want to do the repeated measures because you can get more things out of it. But
And you don't vary things.
but it is important to be careful not to do something goofy or something that is kind of in conflict with.
Yeah. But I would argue that the difference score one also has its goofiness in there, and that's harder to, I find it harder to understand than repeated measures, which lays everything out. And obviously Ron completely disagrees. It's pretty interesting.
Well, my comment on the change score would be that
Because you get a change score out of the repeated measure.
no, I'm not disputing that. I'm just saying that doing the change score model, I agree that the model that controls for baseline value and the model that doesn't control for the baseline value, when the change score is the outcome, those are different models.
Yeah.
And that they could lead to different answers. And I would ordinarily want to look at both and wouldn't necessarily assume that they should always be the same and that they might. I mean, that would be my style.
It makes everyone feel better the result because this is a big bug.
Uh-huh.
So yes, there's positives and negatives, but they're really close. Anyway, okay, so we have two models that are shown here. The first one is the overall just treatment model. Treatment is the only predictor, right? And then the second model, we were looking at effect measure modification of the change in waist circumference, right? And we have treatment and sex, and we have race ethnicity here. So we found that the protease inhibitors had a lower average waist circumference increase. And I'll show this visually in the next slide. This one's pretty dense just numerically, but just giving the takeaways from here. A lower average waist circumference increase over 96 weeks compared to raltegravir. Specifically, darunavir, the significant difference was in mean waist circumference change from baseline for darunavir compared to raltegravir.
So RAL is less increase,
RAL is more.
so it's minus RAL.
So,
and
compared to
behavior.
RAL. Sorry about that. Yeah.
So minus RAL,
Yeah.
and that becomes negative.
Yeah.
So that comes out of, just to close the loop with
Oh, yes,
this
yes,
conversation,
please. Yes, yes.
that's coming out of an interaction term or something with time.
This previous one?
The one,
Yeah, with the time. Yes,
with
treatment and
model
time.
one, that's a
Treatment and time.
And did you find any difference at baseline?
No, I don't think
Okay.
so.
Okay.
Yeah. So the second model had effect measure modifications. Now we have a three-way interaction. So we have treatment, time, and sex. We have treatment, time, and race ethnicity. And so we found that when examining effect measure modification by sex, the treatment difference for a change in waist circumference for atazanavir versus raltegravir was significantly larger for females compared to males. In the next slide, again, we'll see visually it'll be a lot easier to understand. And then we found a significantly larger difference in waist circumference change from baseline for darunavir compared to raltegravir for black individuals compared to other race ethnicities. And we also found that black individuals experienced significantly smaller increase in waist circumference for darunavir compared to atazanavir.
Is there a typo in the slide because the
Oh, is there?
confidence interval overlaps with 0 in the middle of the female versus male and negative 0.65 and 0.92. The middle number in
The middle one of the whole table. Middle row, middle column.
Middle row, this one?
yeah.
Finger up.
Oh, yeah, must be a typo. Sorry about that. I will go back and fix that later. Okay, so here's a visual representation. So we have the treatment and by sex, race, sex and race. So we have females in the top left, males in the top right, black individuals in the bottom left, and other race ethnicities in the bottom right. And so, so I'm going to highlight for females that you see this stark difference in waist circumference increase, which is much higher for the raltegravir arm compared to atazanavir in blue. So I'm just going to come here because I can't use the pointer. So you see this is raltegravir in green, and you see this big difference. And so for black individuals, we see a larger waist circumference increase in raltegravir compared to darunavir, which is in red. Again, same raltegravir is associated with greater waist circumference increases. So next we looked at all the predictors of waist circumference change, and we found that we did this in a complete case analysis model as well as an imputed data model, because when we added in all the confounding variables, there was a lot of missing data. And so we found that darunavir was associated with smaller increases in waist circumference compared to raltegravir, which was consistent with the original intention to treat model that we showed on the previous slide. In addition, so new information, both baseline CD4 as well as HIV RNA appear to be strong predictors of waist circumference change, with higher baseline HIV RNA and lower CD4 levels being associated with higher increases in waist circumference, meaning you have a worse disease state to start off with, and those people had greater increases in waist circumference change over 96 weeks.
So is that the healthy, being healthy? Getting more healthy by the catching up to what BMI ought to be, and the two
That's the next study that we were dealing with. But it could be a healthiness thing, but it could also just be issues with another issue of not starting treatment early enough and getting your disease state going as far. That's what we find in the next study, is that there's an unhealthy weight gain associated with starting, and it could be that starting treatment earlier would help this.
Is that a psychological character? Is that a I wait longer for things, I don't take as good care of my health, and that's why I start later, and that's why I also don't do all these other things that are good for my health? You know, is it due to the medication, or is it just due to the people who delay longer aren't taking as good of their health in general?
Well, we tried to adjust for as much confounding as we could. That would count
Are
for that.
there, so I guess what I'm asking, are there other health behaviors that are in the model that you're controlling?
We didn't have any of that in the clinical trial. As much as we had was just other sociodemographic information.
It was, maybe you mentioned it, I missed, but is
Yeah.
treatment naive people in this one?
Yes.
And do we have any concept of like how long it is since they were infected? Are they all new infections, really new, or?
That wasn't there either. I don't know.
So it could be 5 years and 3 days and all of them.
Maybe it's not. Maybe it was an inclusion-exclusion criteria. I just need to look back and see. There might have been an exclusion criteria for how long they had to have the infection, but I don't know. I guess there's no way of knowing, really.
Well, you can ballpark sometimes, depending on.
You have your baseline CD4 count. So.
Yeah, they had baseline CD4.
You had education in the model?
That was, I'm not sure if that was, it must have been, we could add it in, I guess.
That would, to some extent, answer what higher education is a slight proxy for being healthier. But, trying to think of other covariates you could add in to control for that.
Right, so I think to add to what Rob was saying about people who are treatment naive, I think you have to keep in mind like potential variations among patients who are treatment naive. So I think now there's enough tests available to figure out the recency of HIV infection. So there's ways to see if you're treatment naive, but whether you're relatively recently infected or people who just didn't know about their status for a very long time. So they've been living with the virus for a very long time. And I think the impact of getting on treatment and what happens to your body might have an impact in terms of how long you've been living with the virus. So I think it'd be good to see the inclusion criteria for the ACTG and then figure out if they have that level of information.
Yeah, I think it's definitely correct.
Were these drug users, or what was their risk factors? What were they? Where did they get the virus?
I think that it was pretty random and probably dependent on the site. The sites were all over the country. I don't think it was just drug users. It was probably very site dependent. And there's a mix of people. There are drug users, non-drug users. There are people who have some substance. There are people who don't.
So could you just go back to the last slide? Because I think what I was struck by is that this complete case analysis, you didn't see any, there's no effect, but in the imputed, could you just...
For which one? For which predictor?
I'm looking at the top part.
This part?
Yeah. And I don't see significance there.
Yeah, so...
And then we get
I think it's because I think it's because we had a lot of missing data, so it just because of we included the confounders for this model because we were just looking.
So what was confounding as a randomized trial?
Potential confounding for sex, race, baseline HIV RNA, and.
But all of those are. I mean, this is a large randomized trial.
Yeah.
Why would they be confounded? They have to be related both to the treatment and to the
outcome.
Yeah.
So it's
how
not to the treatment. They could be related to. I mean, treatment is randomized, but these aren't randomized. These other predictors aren't randomized.
Oh, they should be distributed as random.
But the main hypothesis is that you see a difference among the treatments.
But we wanted to look at these as well as individual predictors, so they could be confounded.
I think there might be some disagreement here about what counts as a confound.
Well, treatment's not confounded. We agree on that. And we didn't didn't account for when we just looked at the treatment only model. We didn't adjust for confounding. But because we were interested in these others as individual predictors, they weren't randomized. They could be confounded for the outcome of waist circumference or weight gain or any of the outcomes.
So they didn't stratify any of those other characteristics.
No, but in the top part, we don't see a treatment effect in the complete case analysis. In the imputed data,
I'm going to talk about that. Yeah.
We do see it.
Yes.
And we do see something significant, and the reason seems to be something about confounding.
No, it has to do that we, in this model, adjusted for confounding, and then lost so much data when we adjusted for confounding. We lost like 800 records. There was a lot of missing from the confounding.
And so, I think what I'm so struck by is it's such a large trial.
Yeah.
And I wouldn't think, for evaluating, is there a treatment effect?
No, right. So for the treatment effect, we didn't adjust for confounding, just for the treatment effect. That was in this previous model right here. There was no confounding adjustment here for just treatment. But when we wanted to look at all of the predictors, that's when we did confounding adjustment.
So maybe you can clarify what you mean by confounding variables.
Oh yeah, I said so. We adjusted for drug use, alcohol use, a few other ones.
And all of these
income, insurance.
And all of these are in together, also,
yes.
as well as those you just mentioned.
Yes.
I'm wondering if if the missing ones are more likely to have, differences.
It could be. I think that part of what you're saying is the p-value roughly 0.2 with 800 fewer cases. Then when you add 800 more cases in,
you get back to what you had in the original intention to treat results when you just had treatment alone.
Which is like it's really the upper left-hand number,
yep.
BRD versus
yes.
RAL
yes.
is the one that had a p-value about 0.1.
Yes. Yes.
But I think that there, from a modeling vantage point, there are a number of other things going on, like what the imputation model looks like. It's obviously very involved to give a very thorough explanation of it, and I think you're trying to cover a lot of territory here. But I think that from a methods messaging vantage point is to let everybody know these kinds of like the kinds of things that you were concerned about. It doesn't make sense to me if you're not thinking of it as a compounder. Why would it be significant in one and not significant in another? It needs an explanation like sample size explanation. So that seems
yeah. I guess I could have just focused on one study, but we talked about presenting all of them, and if I just focused on this, I could have easily spent an hour on just this study and going through all the different, there are 7, 8, 9 other tables that I would have shown as well.
What kind of attrition was there in the trial?
About 11, for the outcome of waist circumference was about 11%. But the individuals we made sure to check that the individuals that were lost to follow-up were very similar in all these factors compared to the individuals that were retained through the study.
How many imputations I think there are?
10.
Bottom line is there are a lot of different ways to be misled, and we're sort of probing and finding a number of them. And I think one of the issues that I think your presentation raises is from a presentation vantage point, you sometimes have to make a judgment call of what the bandwidth of the audience can bear, because there's obviously a lot going on. And how to explain when
I guess I was giving this presentation from a more of these are the results that I found in my research vantage than maybe what Cody did last time, which was this is a specific method I used for this thing, and Jay and I had talked that this would be a fine place to do that kind of a presentation.
I really agree.
Yeah.
I just just like we were sort of peppering him with stuff, and I want to be encouraging at the same time as peppering him.
No.
Well, I think Cody completely misread our comments and took it very positively.
You felt really good about the call afterwards. You did good.
That's what happens when you have several professors in the same class.
So you should be like Cody.
Professors who don't get along.
Oh no, I felt bad cutting out a bunch of the stuff I had in detail in here. I cut it out, and I didn't want to cut it out, but then I was like, well, how am I going to get to all of my results? And
Next time you do a 3-hour seminar, you just make us put up with and it only serves us right.
Yeah. I apologize for cutting out the details.
You got to do one or the other.
Yeah, I had to choose path. Okay. So maybe I want to just skip this stuff. This is just the self-report results, and we found similar things with the baseline disease state. We also found that being a female was associated with reporting a higher self-reported abdominal size gain, which could be psychological, not necessarily that females had a greater abdominal fat gain, because we didn't find that with waist circumference.
So none of the previous stuff was intention to treat?
Which one?
The previous analyses from study 2?
Yeah, it was all intention.
Oh, it's still,
yeah, it's all intention to treat. Yeah.
Okay.
I had all the other protocols, all that stuff, I took it out, but they were all consistent, similar results. Maybe stronger in the per protocol, which would make sense. Okay, so I'm just going to skip to study 3, which I think we brought up a couple of times. So this study was examining predictors of severe weight gain, and this was trying to get at kind of this unhealthy weight gain that we see in individuals initiating therapy. Just to give some background, so earlier in the epidemic, as everybody knows, wasting was more commonly associated with HIV infection, and ARV therapy has led to individuals regaining their weight as a return to health. This has resulted in a shift of the epidemic towards more overweight obesity, which is what's being seen a lot in a lot of cohort studies all over the country. And so the increased health risks from the metabolic comorbidities may outweigh the benefits of weight gain for normal to high BMI individuals initiating therapy. And so as weight gain and cardiovascular disease become more of an important issue for those infected with HIV, it's important to understand the various risk factors that may lead to increases in weight for this population. So this is kind of getting at what we were talking earlier, like how do we know if somebody's just gaining weight because they were unhealthy or not. So we tried the best we could within this study framework. So my objective of the study was to understand the underlying predictors of severe weight gain in HIV-infected individuals initiating therapy. And so, again, we had the same type of predictors we were looking at, but the difference is how we defined our outcomes. So as a sensitivity, we defined two outcomes. One was a severe weight gain outcome, which was defined as people who were normal at baseline, normal BMI at baseline, and had a greater than or equal to 10% gain of weight. And we didn't want to completely exclude those that were underweight at baseline. So those who were underweight at baseline that had an increase of more than 2 BMI categories and a greater than 10% gain in weight were also included as having the outcome. And then for the second outcome, severe BMI gain, again, normal at baseline but moved upward of at least 1 BMI category, or underweight at baseline and increased more than 2 BMI categories. So we used logistic regression modeling, and we did multivariate models, including all the predictors that we were interested in, and adjusted for confounding again for these confounders that we had: smoking, drinking, drug use, income status, and insurance status. So, what did we find? So, we found a protective association between, this is dealing with the severe weight gain outcome, the first outcome.
So, just make sure I got that outcome.
Yeah.
Is severe weight gain always bad? When I saw how you defined severe, you had also if you were very underweight and you gained. That could be good, right?
But then we tried to distinguish it because then they had a real big shoot, not just like a normal gain in weight, kind of like too much weight gain. So for those who are underweight, that, for example, for the severe weight gain, moved upwards of 2 BMI categories.
So what is a BMI category?
So
2 BMI categories, it cannot be good? Oh, if you're really...
It could, but we were trying our best to distinguish unhealthy weight gain from healthy weight gain. So if you're underweight and within the time frame of the study you went to normal weight, you couldn't say that was unhealthy weight gain. That probably was healthy weight gain. But if you were underweight and you went to overweight,
in
96 weeks, we are thinking that could be an unhealthy weight gain. Because I just actually it was interesting, I just went to COI with this presentation, and it was interesting, I had so many clinicians coming up to me just saying, I'm seeing, like, this one guy from India was like, I'm seeing this in my clinic, I don't know how to explain it, I just see these people coming in now, they're really, really overweight, and I don't know what's going on. So just we tried our best within the framework to try and define what is this unhealthy weight gain from somebody who just gained weight because they were, starting treatment.
Like in the current field, is there a standard definition of how you would define what unhealthy weight gain is?
No, I think that this has just been observed like here and there in a few clinical trials, oh, we noticed that there are these people that really shot up. What's making them different? And so that's where we kind of got the hypothesis to do this study. So we found that for atazanavir compared to valtegravir, that there was a higher odds of severe weight gain, and then we also found for black individuals compared to white individuals that they were at a higher odds of severe weight gain, and again, higher RNA and lower CD4 consistent with the previous study associated with a higher odds of severe weight gain. And so now, the previous study we didn't account for unhealthy abdominal fat gain, but this one was trying to distinguish healthy from unhealthy weight gain at least. So the disease severity at baseline was associated with this weight gain.
What's the just basics, like how many people are we looking at in this, and how many have that hit the criteria?
Had the outcome? I'd say, so this was the whole cohort of 1,800 individuals. So about 1,600 had follow-up measurements, and the outcome, I think, about 200 to 300 had the outcome.
10 to 15%.
Yeah.
So age has nothing to do with the weight gain. That's surprising.
Yeah.
Because normally age.
And sex, we didn't find sex had anything to do with it either.
Yeah,
we expected
against
females.
the common knowledge.
Yeah. So for the other outcome of severe BMI gain, we found the same results. They were consistent, except we found for darunavir was associated with a higher odds of severe BMI gain compared to raltegravir. But directionally, they were both consistent. I mean, the p-values, they were different. One was low significance, but the odds were directionally consistent between the two outcomes. And so, from the results, it appears that treatment with a protease inhibitor may be protective against severe weight or BMI gain compared to treatment with the integrase inhibitor raltegravir. And another thing that somebody brought up during CROI, which was a good point, was people on protease inhibitors apparently experience more nausea. So maybe that's why they're not having this severe weight gain. But I know from the primary analysis that was done for the study, I don't think they found much difference in nausea between the different regimens. So that was one thing that could have maybe accounted for it. And our results also found that black non-Hispanic individuals had significantly higher odds of severe weight gain, which is consistent with previous research. And
that's the same on or off medication, right? Is that just a general racial ethnic trend regardless of medication, or?
Yeah, that's just yeah. And then we found a strong association between baseline disease state before antiretroviral therapy initiation and increased odds of severe weight and BMI gain. So the overall summary. Some strengths of the research is just going back to all the studies, that we had collected CT and DEXA measurements that had measured change in weight, change in abdominal fat over time, and that we had this longitudinal study to examine body fat assessment over time, which is something that a lot of other studies haven't been able to look at, and that we were able to use this high-quality clinical trial data, and that we had a large sample size and had men and women of different races, so a pretty diverse group of individuals. And a few limitations that we had is that we had lost follow-up from the study, but we further investigated that they had similar characteristics to the rest of the study population, those who were lost to follow-up. And there were also missing data on the covariates, and we tried to address this through multi-use mutation. And that, of course, the trial is, had strict inclusion and exclusion criteria, so maybe it's not as generalizable to all the HIV populations. But it was still, for a clinical trial, pretty diverse. And that we didn't have information on diet and exercise, which would have been really key for our study. I wish we had that information. So with that, I wanted to say thank you, and I wanted to thank the dissertation committee for all their guidance. Okay.
So we got about 5 minutes. Any more remaining questions for Priya?
Yes.
Well, just first of all, the scope was impressive, and I also want to really salute your, it gives the feel that you really delved into the modeling and explored a lot of variations, which is really encouraging and a really the kind of direction that I like to encourage a lot. But I was going to sort of passing comment on you skipped past that study where there was a reference to ordinal logistic regression. I just wanted to mention there's a similar issue that I have with the kind of thing that Dr. Kirschmeyer was talking about the difference between like you wouldn't want to have a longitudinal model with a treatment effect on baseline measure that was the same as the treatment effect post-baseline. With ordinal logistic regression, if you don't build in certain interactions, then a lot of times what will be implicitly assumed is that the effect of covariate that takes you from level 0 to level 1 of the outcome is the same as the effect of the covariate from level 1 to level 2.
Yeah.
You can specify the model to modify that, but a lot of times people don't.
Yeah.
And so I just wanted to say it out loud. It's a similar issue.
Flexibility.
Like if you're going to do the kind of longitudinal modeling that Dr. Weiss is favoring, make sure you're paying attention to issues like that, the baseline thing. Similarly, on the ordinal logistic regression, I would say make sure to pay attention to that you aren't making certain implicit, stylized assumptions that might not make a lot of sense in the applied context.
Yeah.
Just a thought for maybe additional investigations, or maybe you've looked at this already. One of the main findings that you had said for the main clinical trial was that, and sorry, I can't pronounce all these drugs. You're really good at that, by the way.
I had to at Priya,
but was that one of them was better tolerated than another.
Yeah.
And I was wondering if you'd done anything or thought about doing something sort of with a time. Some people may drop out or because it's not being well tolerated, and I think that follows up some of the comments earlier, and how that interacts, that maybe it's not being tolerated, and so that they're, and is that information available using when they, and could that be done in some sort of time bearing?
Yeah, we're actually talked about doing some follow-up about, a lot of things I think that I would like to dig in deeper also, like when is this happening? When is their weight gain happening? And also just like that, when is tolerability, when is it becoming intolerable? Like incorporate these things, like is everyone gaining weight in the first few months? Is it in the first year? Is it in the second year? And so kind of digging deeper. So yes, we talked about doing that. Would be really interesting to dig deeper into when are these things happening? And for those that it happens sooner rather than later, and like what's the differences there? Yeah.
So Priya, thanks for sharing your work, and I think this was, very informative, and I hope that you take, our esteemed biostatistics advice to heart. And
with a grain of salt.
So I think,
salt and take it to heart. Doesn't that lead to hypertension?
I think the population is interesting, and I think, you're dealing with folks who are enrolled in the clinical trial, right? And I think just the idea that people are on treatment and they're having regular, access to a provider, and I think the idea of like monitoring diet and exercise, I think that's key when you think about patients in general. So none of us are getting any younger, and I think as time goes on, I think one of the things that I'm interested in is patients who are living with HIV. I think providers put a lot more effort on making sure you're on treatment, right? So there's other doctor advice that you can give, whether eating healthy and diet and exercise. It could be perceived as a secondary objective for the 5-minute doctor visit, and they're more interested in making sure that you're adhering to the regimen so your viral load stays suppressed. So I think in terms of provider engagement implications, I think and I know that we brought up age, but this was only like a 98-week follow-up. But I'm sure all of us, as we get older, it's harder to manage our weight. So it's just, I think that's always something that we should keep in mind. And I think patients living with HIV is sort of a different risk group than folks who are going in for a flu shot or going in for a cold.
Yeah. One of the places, just getting off of what you said, is really, really good points. But that we wanted to go with this is kind of like two so whats. So we wanted to take this and say, can we do some like a testing and a validation population, try and come up with like a risk score that then doctors could pay more attention to these groups, and then as you said, like focus on diet, focus on exercising and things like that. So that was one thing I didn't have time to do, but maybe I could get some time to do something like that. And the other thing was kind of, are these changes in weight really like, are they bad or are they good? And kind of seeing looking at some of the more of the metabolic measurements and kind of seeing what's going on there with these changes. So, but yeah, with the diet and exercise is a really good point.
Thank you.
Thank you.